A very good day to you all. At the outset, I would like to thank Dr. Meena for asking me to present this keynote on IOL considerations in glaucoma patients. Last few decades have seen newer lenses of more advanced technology and design being incrementally added to the arsenal of the cataract surgeon. Though these lenses have pushed the concept of refractive cataract surgery, they come with certain downsides. Hence, it becomes important for us to choose these lenses appropriately for glaucoma patients who are all unique in terms of pre-existing structural and functional changes and need special considerations. We were plagued with the issue of the blue blocking lenses with the yellow chromophore and their impact on visual field testing during the early part of this century. Then, when we started noticing glistenings in certain optic biomaterials, we wondered about the effect on light transmission and if this should become an important factor in choosing intraocular lenses for our glaucoma patients. The issue of using lenses with hydrophilic optic biomaterial also became important in light of optic calcification noticed in surgeries involving retention of intracameral air bubble. And finally, the presbyopia correcting intraocular lenses. I will deal with the topics in the reverse order. Currently, a surgeon has access to a variety of premium IOL designs to extend the range of spectacle independent vision. Glaucoma patients having cataract surgery want the same thing as other patients, the best possible uncorrected vision. They want refractive cataract surgery. However, we must adhere to the principle of primum non nocere. There is often a trade-off to the range of vision gained with the advanced technology intraocular lenses, namely diminished contrast sensitivity and quality of vision and an increased risk of dysphotopsia. For patients with glaucoma and already reduced contrast sensitivity, the potential for further compromise of quality of vision is particularly concerning. There are a number of concerns in the use of multifocal IOLs in glaucomatous eyes, and these include a loss in mean deviation on standard automated perimetry using size 3 and size 5 and wavy artifacts on OCT imaging, which could complicate the ongoing monitoring of the diseased eyes. Roger Steinert and his group looked into the reduction in mean deviation values in automated perimetry in eyes with multifocal lenses compared to monofocal intraocular lens implants and found a significant depression in the mean deviation in the multifocal intraocular lens group. The study concluded that multifocal IOL implants may be inadvisable in patients where central visual field reduction may not be tolerated, such as macular degeneration, retinal pigment epithelium changes, and glaucoma. Similar findings were noticed in another study employing HFA visual field 30-2. Glaucoma results in a reduction in contrast sensitivity at low spatial frequencies, which typically exacerbates the loss of contrast sensitivity that occurs naturally with age. This reduction in contrast sensitivity has been shown to be correlated with progression of the disease. I will be dealing with this problem in greater detail a little while from now. Patients with glaucoma may be more likely to have smaller pupils, and pupil-dependent technologies such as refractive multifocal intraocular lenses may not perform as well in pupils which are smaller than 3.5 mm. Pseudoexfoliation glaucoma is another specific risk factor because of the presence of loose zonules, small pupil, and the tendency for an aggressive PCO with intraocular lens decentration in the postoperative period. For these reasons, it is not a good idea to use a multifocal intraocular lenses in these patients. So now back to the reduced contrast sensitivity in glaucoma patients. The literature has shown that there is a linear relationship between the mean deviation on visual field testing and contrast sensitivity. The higher the mean deviation, the worse the contrast sensitivity. The figure on the left shows the level of contrast per disease stage circled on the Paley-Robson chart to illustrate decreasing contrast more clearly in a patient with glaucoma. So, the dictum to be followed whenever we perform cataract surgery in these patients is avoid any intervention that may further reduce contrast sensitivity. The visual system is always compromised if a multifocal intraocular lens is implanted. The contrast is reduced. With certain multifocal lens models, there is more difficulty reading under low light conditions, and of course we are aware of the positive dysphotopsia, the halos, etc., glare, etc. happening around point sources of light. So, what exactly is the current status of multifocal lenses in glaucoma? There is not much available in the published literature. A recent study published in the Journal of Ophthalmology in June 2021 looked into the visual function in patients with pre-perimetric and perimetric glaucoma implanted with multifocal intraocular lenses. It showed that non-diseased eyes had statistically better monocular distance uncorrected visual acuity and distance best corrected visual acuity, as well as better low contrast visual acuity than glaucomatous eyes. It also showed that patients with glaucoma had more difficulty driving at night, and the differences between non-diseased eyes and eyes with pre-perimetric glaucoma were not statistically significant. The multifocal IOLs that have more recently emerged appear to be associated with fewer side effects related to contrast sensitivity loss and visual disturbances than their predecessors, but concerns surrounding these risks remain. The figure to the left demonstrates the contrast sensitivity function for the Acrysof IQ panoptics trifocal intraocular lens compared with that of a monofocal intraocular lens. In this analysis, no clinically meaningful difference in contrast sensitivity was observed between the panoptics lens and the monofocal equivalent at any spatial frequency, regardless of the presence of glare and in both mesopic and photopic conditions. The extended depth of focus intraocular lenses have recently emerged and appear to be quite promising. In a comparative analysis published in JCRS in February 2018, there was no significant difference in contrast sensitivity function between Tecnis Symphony and Tecnis monofocal intraocular lens. In a subsequent study in BMC Ophthalmology published in 2019, it was shown that in terms of contrast sensitivity function, Symphony lens was in between the monofocal and the multifocal intraocular lenses. And in terms of halo and spectacle independence, the performance was quite similar to trifocal intraocular lenses. So, Tecnis Symphony may be considered in patients with underlying comorbidities affecting the contrast sensitivity function. However, halos and glare are potential concerns due to the diffractive design of this platform. Another extended depth of focus IOL, the Acrysof IQ Vivity, also appears to be quite promising. In the FDA study, it was noticed that the visual disturbance profile was similar to that of a monofocal intraocular lens. It also showed reductions in monocular mesopic contrast sensitivity with increasing spatial frequency, although binocular contrast sensitivity is not significantly different from that with a monofocal intraocular lens. Hence, Vivity may also have a greater role in patients with comorbidities. Its impact on contrast sensitivity requires further study. The Tecnis Eyhance lens is a refractive monofocal IOL that doesn't meet the full EDOF criteria but provides some additional intermediate vision with a power change over the central optic. It has a visual disturbance profile similar to that of the standard monofocal intraocular lens, and the contrast sensitivity profile is similar to that of an aspheric intraocular lens. Hence, it appears suitable for all patients with glaucoma. When the Tecnis Eyhance IOL is used, the tendency is to employ a mini monovision wherein we target -1 diopter in the non-dominant eye. So, what are the indications for multifocal intraocular lenses or presbyopia carotenic lenses in patients with glaucoma? These lenses can be safely used in glaucoma suspects, ocular hypertension patients, patients with early or mild glaucoma damage that has been controlled and stable, and patients without any signs of glaucoma progression. There are certain situations where multifocal lenses should not be used, and this include patients with advanced disease, patients with central visual field defects, those who have a high risk for glaucoma progression, and patients on heavy medication load. So, when an advanced glaucoma patient where the multifocal IOL criteria are not fulfilled, and if the patient is requesting for spectacle independence, what are the choices we have? Well, we can always consider a monovision with an aspheric intraocular lens, which as such is associated with high spectacle independence. There is no image degradation that is seen with this method, and it retains the potential for best corrected visual acuity when needed. In patients with moderate glaucoma, an extended depth of focus lens, for example the Symphony or the Vivity, may be considered, and an enhanced monofocal IOL can be considered in all diseased states. Another factor that has to be kept in the mind while considering a multifocal intraocular lens in a glaucoma patient is the tear film, which happens to be the most important refractive surface of the eye. Any disruption of the ocular surface induces a distortion that is magnified by a multifocal IOL. So there is a kind of a stacking up effect. Optical quality disruption because of the multifocal lens and because of the unhealthy ocular surface, they stack up together. So this image shows you a glare and halo in a patient with multifocal intraocular lens with significant OSD on the right side and on the left side without any significant ocular surface disease. Ocular surface disease is quite common in glaucoma patients because of multiple reasons, because the patient has been on topical medications for a long time, large blebs, meibomian gland dysfunction, and conjunctival inflammation and scarring. So before these patients are taken up for multifocal intraocular lens evaluation and surgery, ocular surface optimization in the preoperative period is very, very important. It is important to identify and treat dry eye and blepharitis in the preoperative period because these conditions can impact keratometry as well as topography, thereby affecting the precision of IOL calculations and precision of measurement of axis and magnitude in the case of toric intraocular lenses. Toric IOLs do extremely well in glaucoma patients provided preoperative diagnostics have been looked into and the toric lens as well as the toric markings have been properly and skillfully done. It goes without saying that the regular list of contraindications have to be respected. Personally, I have been quite happy with the outcomes of using toric IOLs in my glaucoma patients. There is adequate support in the literature too. In fact, this article from Journal of Refractive Surgery concluded that toric intraocular lenses can reliably reduce astigmatism and improve uncorrected vision in eyes with cataract and glaucoma. Toric IOLs in glaucoma patients needing combined surgery is a different cup of tea, and usually I don't use a toric IOL in such scenarios. That's because of the unpredictable induced with the rule astigmatism that is seen after trabeculectomy, particularly when mitomycin C has been used for the trabeculectomy. The blue blocking lenses have generated some discussion in the scenario of glaucoma patients, particularly when they're first introduced into the market. So this particular study looked into the effect of yellow tinted intraocular lenses on standard automated perimetry as well as short wavelength automated perimetry in patients with glaucoma, and concluded that in mild to moderate glaucoma patients with cataract, the perimetry indices of swab testing improved after phaco and yellow tinted intraocular lenses. It also showed that the yellow tinted intraocular lenses have less effect on swab testing than visually significant cataracts. Over a period of years, we have noticed the glistenings in certain intraocular lenses, particularly hydrophobic acrylic biomaterial lenses, and have wondered whether the effect on light transmission of glistenings may have adverse effect in glaucoma patients. This study in 2014 looked into glistening in glaucomatous eyes and found that glistening severity increased with time and the chronic use of eye drops. It also showed that glistening in glaucomatous eyes altered visual performances in reducing contrast sensitivity at high spatial resolution and in overestimating focal defects analyzed by standard automated perimetry. The effect of glistening on visual performances should be a consideration for patients having age-related diseases and above all glaucoma patients who are more likely to develop glistening within the IOL optic. So, IOL inducing the least glistening formation should be recommended for glaucoma patients who require cataract surgery. All said and done, the surgeon must use current and newer IOL formulas to get optimal results. IOL power calculation may get a little complicated in the scenarios mentioned here, particularly in the setting of a trabeculectomy. In certain situations, you may expect a myopic shift and in others a hyperopic shift. So these have to be factored in while counseling such a patient for cataract surgery and while setting the target refraction in the postoperative period. So friends, in conclusion, as surgeons, our job is to improve patients' quality of life, which most of the time is reduced spectacle independence. No glaucoma patient should be ruled out as a premium IOL candidate because of his glaucoma status. The IOL selection should depend on a patient's interest in spectacle independence, his visual expectations and needs, risk tolerance, and severity of glaucoma and medication load. As a modern presbyopia correcting intraocular lenses evolve and improve, an increasing number of glaucoma patients may benefit from new technology intraocular lenses. Thank you very much for your kind attention.